It's the PainExam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the PainExam newsletter at PainExam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the PainExam app with a premium subscription or access for free with a CME subscription at PainExam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back and thanks for joining us. A few announcements before we start. My monthly ultrasound courses are revamping starting December 21st, then January 11th, and so on. Almost every month, we're going to be having an ultrasound course in New York. But if you can't make it to New York, I also do private sessions, and we're full for January. I'm booking now in February, and so on. So if you're interested in either observing me in my office or having a private session close to you, that can possibly be arranged. Just reach out to me via the info@nrappain.org or just email me at drosenblum@rmcpain.com. Of course, now is the best time for board prep. So if you're studying for your pain boards, you do the virtual pain fellowship, you'll have plenty of content to keep you busy, as well as CME credits until the next exam. And all that's located at nrappain.org, NRAP, neuromodulation, regional anesthesia, and pain. So, as you guys know, if you're following me, I'm doing a lot of ultrasound work as well as regenerative medicine in my pain practice, and the two go hand in hand. Of course, when I'm doing my X-ray guided spine PRPs or BMACs, it's mainly without the ultrasound. Although in the neck, I am using the ultrasound. At my last two courses, I had my own PRP injected in my neck under ultrasound, and believe it or not, it actually worked. And it was not even in the disc or even in the epidural space. It was in the perifacet region and in the extraforaminal space where the nerve leaves. And lo and behold, it actually worked. I was surprised, but not surprised. So I have this age-old question, which is something that comes up when I talk to my patients about PRP versus BMAC, because at this point in time, it's probably the most ethical, effective, safest treatment I can offer my patient to get back to themselves and to actually heal themselves. I do believe it's superior to steroid injections, but unfortunately it's cost prohibitive for many people, as we all know that. So the big question is, when there's a patient who is fortunate enough to be able to afford BMAC or PRP, is which one to advise them. And I'm of the school of thought, I don't really advise anything. I educate, and I tell the patient, hey, these are the facts to my knowledge, pros and cons. This is where we stand with the evidence. And there are some studies of PRP versus BMAC for certain body parts. However, as we all know, or you should know, or you may not know, the BMAC is Bone Marrow Aspirate Concentrate. That's a more invasive procedure, but and it's more costly, but it may actually be more effective. And the question is it truly more effective? Well, I found some studies, and unfortunately, I didn't really find the gold standard study I'm looking for where I could confidently tell people, you got to do the BMAC first because it's better for you. No, what I'm actually telling people more or less is try the PRP first because it's cheaper, it's less invasive, and if it works, you're done. However, according to what I'm about to go over here, you may want, I may reconsider that. So the first study I'm looking at, and of course the studies will be in the show notes, is a study titled Bone Marrow Aspirate Concentrate versus Platelet-Rich Plasma for treating knee osteoarthritis, a 1-year, non-randomized retrospective comparative study. So it's non-randomized, so don't get too excited here. However, it's something. They did look at knee arthritis, as I mentioned, and They measured the functionality and pain scores at baseline and at different time points post-injection over 12 months using 3 self-administered clinically validated questionnaires, the VAS, the Knee Injury and Osteoarthritis Outcome Scores, otherwise known as the KOOS, KOOS, and that evaluates the functionality and the quality of life for knee patients, and the Western Ontario McMaster University's Arthritis Index, the WOMAC. And they also looked at the BMAC group, which had 26 knees. Once again, not 26,000 knees. It was 26 knees. So don't get too excited. And they saw a significant improvement between baseline and 12 months. The PRP had non-significant improvement in the 13 knees that were looked at. And they said in comparison in their conclusion, the PRP and the BMAC produced significant improvement and is more effective in functionality and pain reduction than the PRP. I found this interesting because of almost every study I read about PRP in the knee says there's significant improvement. Here they're saying, according to their study, or the way they measure it, it was non-significant, which I'm kind of shocked at. But anyway, it is what it is, right? So after this study, you could say, hey, don't do PRP, do BMAC. Of course, there's another study showing PRP is superior to gel, viscosupplement, steroids, or placebo. So take everything with a grain of caution. This is a 1-year, non-randomized, retrospective comparative study with only about 40 patients altogether. So really, is it worthless? No, I don't think it's worthless, but it's not really what we want. But unfortunately, I can't find exactly what I want. But there is a study that was much larger because it was a meta-analysis. It was a systematic review entitled Patients with Knee Osteoarthritis Who Received Platelet-Rich Plasma or Bone Marrow Aspirate Concentrate Injections Have Better Outcomes Than Patients Who Receive Hyaluronic Acid. Systematic Review and Meta-Analysis. So this doesn't surprise me because I read another similar study, and here, it's not really telling you which is better, the BMAC or the PRP. However, it's making me feel more confident that I'm telling people the right thing, that both the PRP and the BMAC are probably the way to go if you have chronic knee arthritis. Here, it wasn't 27 patients. It was 27 studies, all level 1, that met inclusion criteria, including 1,042 patients undergoing intra-articular injections with PRP, 226 patients with BMAC, and 1,128 patients with hyaluronic acid. The meta-analysis demonstrates significantly better post-injection WOMAC and subjective IKDC scores in patients who receive PRP compared with patients who receive hyaluronic acid. Not surprising. Similarly, network meta-analyses demonstrate significantly better post-injection WOMAC and subjective IKDC scores in patients who received the BMAC compared to the hyaluronic acid. There was no significant differences in post-injection outcomes when comparing PRP with BMAC. So if it was not statistically significantly different, why would you tell people to do BMAC over PRP? Well, I'll tell you why. The first study suggests you should. However, that was only 26 people, or 39 people altogether, I think. So once again, when having the conversation, especially if hyaluronic acid is not covered by the patient's insurance, which I'm seeing more and more, perhaps you should just abandon it and tell people, well, just do the PRP, right? If it's gonna, it might even be cheaper depending on how much your practice charges for it. And this is a level 1 meta-analysis of level 1 studies. So this is a quality review according to what I guess their own self-assessment. But this I think in my book this carries weight. So in a previous podcast, I remember stating that steroid it was not my statement. It was a statement of the author. Steroid injection into the muscle for multifidus atrophy may be considered unethical. Well, can we say steroid knee injections, which is standard of care, not best care, but standard of care, can we say that is unethical? Well, I'd say all things aside, all money aside, well, yeah, we shouldn't be doing it, but that's what's paid for, and that's cheap. The other thing to consider is steroid will get them back to function sooner. So, when my shoulder had an issue a year ago, I couldn't move. I could barely lift my arm up to do x-ray shots. So I got the steroid, and that worked wonders. Now I'm having a low-grade, rotator cuff inflammation. I'm going to do the PRP, right? So I think it's situationally dependent on what's going on. Okay, a third study, PRP versus BMAC concentrate. This is just an overview of the mechanisms of actions of orthobiologics to synergistic effects. So, I mean, I've talked about this a million times. There is a lot of platelets, obviously, in PRP. Here they're saying 3 to 5 times above baseline. I don't know. I go for 8 to 10 times. I have higher standards, I guess. You want to have more platelets to have more of an effect. And from what I understand, and I saw this in a study, which I forgot where it was, as well as I heard this at one of the ASIP meetings when the regenerative medicine guys were talking. The older patients tend to respond more to platelet concentration than the younger patients, and that could be because of the suggested mechanism is upregulation of receptors. Since they're not used to seeing so many growth factors, there's an upregulation of those receptors for the growth factors in the elderly, so there's more of a dose-dependent response. Anyway, they do mention concentrations over 1.5 million platelets per microliter might cause inhibition of stem cell proliferation in vitro settings. That's interesting. So maybe you don't want too many platelets. Anyway, I would be definitely interested in hearing more about that, but I'm just telling you what they say here. The biological mechanism driving the clinical use of PRP involves the activation of growth factors released from the alpha granules of activated platelets. VEGF, EGF, PDGF. I mean, I've talked about this a million times. I'm not going to go into every little one. Upon activation, platelets will seek out the receptors on the cell membrane of surface stem cells. The cells have receptors that bind growth factors and in turn elicit local downstream effects. There's migration, differentiation, proliferation of cells, as well as extracellular matrix biosynthesis driving tissue repair and regeneration. There are other types of cells like neutrophils, monocytes, macrophages, fibroblasts that are in PRP. Depending on how you process it, there could be varying levels. And it's noted that other cells may participate in the healing process, such as white blood cells. They can combine with platelets to stimulate the generation of anti-inflammatory cytokines, even though they are naturally involved in the important role in microbiocidal activity with the production of inflammatory cytokines. There's also the fibrin biopolymer, which is a final product of a platelet cascade activation that acts as a temporary three-dimensional extracellular matrix, providing a suitable vehicle for the delivery of bioactive molecules such as growth factors. When platelets are activated, there's an initial burst of growth factors that is later stabilized and kept under a sustained release. So there really is a lot of debate about the leukocytes. They are getting into leukocyte in the PRP here, and they mentioned that leukocyte rich and poor have similar safety profiles in response to adverse reactions, and leukocyte-rich PRP does not modify systemic and local levels of pro-inflammatory cytokines in these, for example. The rationale to use the rich leukocyte PRP would be more for crosstalk between platelets and neutrophils. You have an initial release of inflammatory molecules, arachidonic acid, leukotrienes, prostaglandins, lipoxin A4, and it stops the signals from prime neutrophils to prevent neutrophil activation. In regard to the influence of the type of PRP on MSC cultures, leukocyte-rich PRP is able to induce significantly higher proliferation of bone marrow MSCs when compared to pure PRP or platelet-poor plasma samples with faster release and better biological activity of growth factors. Now, reviewing bone marrow aspirate. Now, you got to be careful. A lot of people call this the stem cell procedure. You cannot call it that. The FDA does not like that. Are there stem cells here? Sure. But really, we're talking MSCs, mesenchymal stromal cells. That's, I guess, the most accurate way to describe this procedure. And basically, the International Society for Cellular Therapy position statement has 4 minimum criteria for MSC identification. They must be plastic adherent when cultured under standard conditions. They must demonstrate capacity for osteogenic, adipogenic, and chondrogenic differentiation. And they must express CD73, CD90, CD105, and they must lack expression of hematopoietic lineage markers like CD34, CD45, CD14, HLA, DR. The number of progenitor cells in BMAC correlates with positive outcomes. However, obtaining a high number of cells depends on several factors like age of the patient and the method used, the technique when getting the cells or bone marrow. Now, in this article, they're saying MSCs are mesenchymal stromal stem cells. I do omit the word stem cell when I'm talking to patients or any sort of advertisement marketing, just to stay on the safe side with the FDA. And also, really, the stem cells are a very small proportion. It's like 1 cell out of every 10,000 cell on average, depending on the individual's age. They are easy to isolate because MSCs can be obtained from the bone marrow, adipose tissue, dental pulp, umbilical cord, fetal liver, amniotic fluid. They possess a strategic role in the regenerative process and self-renewal proliferation. We know all this. And some parasites are attracted to the area of injury and become activated MSCs, and they do have immunomodulatory, anti-inflammatory, and anti-apoptotic mechanisms that will vary according to the environment, and as a response, will secrete large quantities of different bioactive molecules. So, at birth, bone marrow becomes the only responsible tissue for production of hematopoietic and stromal cells. Briefly, hematopoietic cells are responsible for giving rise to other bloodlines such as red blood cells, leukocytes, platelets, granulocytes. On the other hand, MSCs can differentiate into fibroblasts, osteoblasts, osteocytes, adipocytes, and chondrocytes, all the good stuff you want for healing and regeneration. And they can stimulate additional stem cells from intact bone marrow to travel to the site of injury for healing. So, hematopoietic stem cells can also do this. So there's a lot going on with this, and the advantage of the BMAC is that the technique is considered minimally cellular manipulation. Thus, the FDA approves it for the delivery of stem cells. Once again, just don't advertise it as stem cells. It contains mixed cell populations that enhance the performance of MSCs in contact with their physiological niche. It's considered a low-risk procedure with respect to hemorrhage, joint pain, and swelling. Much like PRP, BMAC has some discrepancies in obtaining it and the way people process it. There's really, a lot of the stuff is still Wild West, not really standardized. Syringe sizes are preferably 10 mLs, and aspiration volumes of 3 to 4 cc's per syringe should be considered because higher sizes and volumes per puncture might induce diluted samples with fewer MSCs. There's a technique to taking this out of the bone marrow. If you've never done this, you want to rotate it. You don't want to keep sucking out from the same spot. And by the way, the most painful part of bone marrow aspirate is not putting a needle into the bone. It's actually the aspiration of the bone. That's quite painful. So some patients want anesthesia for that. Manual extraction of the buffy coat, and these are things that could vary if you're not careful. So you just got to be careful how you process it. And like everything, it's an art form, it's a practice. You want to fine tune your technique. This study talks about a level 1 study where they used autologous BMAC combined with PRP at the site of the ostomy, and they saw improvement in bone regeneration. I mean, a lot of people are combining PRP with BMAC, and you can read about it yourself. There is definitely a benefit according to many studies. Here's a study they're quoting: the osteonecrosis of the femoral head. They treated with PRP plus BMAC and good augmentation strategy during the minimally invasive decompression. At the end, the author concludes that there's a big benefit to adding PRP to BMAC because the PRP serves as a cultural media for the MSCs in the BMAC. So it's something to consider. Of course, not every patient has the budget for BMAC or BMAC plus PRP procedure, which can be time-consuming and quite expensive. And lastly, I have a study here that mentions BMAC with and without PRP for treating rotator cuff tears, and they found that in this limited analysis, BMAC alone is equally effective as using BMAC and PRP with respect to treating rotator cuff tears. And this was a meta-analysis, so it's something just to keep in mind. Unfortunately, this one does not have PRP versus BMAC. I've definitely used BMAC for rotator cuff tears. It works really well. So does PRP. So I guess time will tell how much better and if we should combine them or not. See, there's still a lot of questions with respect to regenerative medicine. That's why I'm still talking about it, and I'm always looking for new data. Thank you for listening. I appreciate everybody. Please review the podcast if you're happy with the content. If you're not, feel free to email me, and I take requests. Or if you want to be on the podcast, I'm always happy to interview someone at 6:30 a.m. Eastern Time on a Wednesday. And I hope to see you guys at a conference or one of my courses. And once again, if you're interested in board prep, go to nrappain.org or just email me if you want to have a private ultrasound, whether you can observe me in my office or set up a private course or just come to one of the workshops at our upcoming conferences with our partners in Dubai or elsewhere. I'll keep you posted once I confirm that I will be running ultrasound courses at these conferences. So hopefully you can make your plans and we can meet up. Thanks again. Have a great day.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.